Hello and welcome to the ROS1ders. We are talking today about the basics of ROS1 positive cancer. I'm Janet Freeman Daly, one of the founders of the ROS1ders. I was diagnosed with lung cancer in 2011, had 2 different lines of chemo and radiation, both of which I progressed immediately afterwards. And then in November 2011, started taking a targeted therapy called crizotinib for ROS1 positive cancer, and I've had no evidence of disease ever since. The ROS1ders is a group of international caregivers and patients all dealing with ROS1 positive cancers. Our goals are to support patients and caregivers, increase education and awareness of ROS1 positive cancers, accelerate research, and improve access to effective diagnosis and treatment for our disease. I see that Angie and Christine have joined us. Great to see you. Margaret Hoffman, Carol Brickle, Lisa Goldman. Glad you're with us. Our organization was founded in 2015 by a group of ROS1 positive cancer patients. We all met, at the Longevity Hope Summit in 2015. We all had children at home, we were all on crizotinib, and we all had no next treatment. We founded this group to change all that. We are now an actual nonprofit organization. We have almost 600 members in over 30 countries, and we work with nonprofits, doctors, and hospitals to try and improve ROS1 positive cancer outcomes. Today we're going to be talking about the basics of ROS1 positive cancer. I'm not going to go into the details about what happens when your TKI stops working or current clinical trial results. We will have a follow-on Zoom call with Dr. Ross Camage to discuss that information. But I am going to talk about the basics so people can get up to speed about what ROS1 positive cancer is. So first, I'm going to try an experiment and see if I can get this poll to run. I'm going to publish a poll for the first time. Hopefully you can see it now. Please click on your answer to tell us how long ago you or the patient you care about was diagnosed with ROS1 positive cancer. Hopefully everybody can see the poll. And I'm going to leave it up just for another minute or so to give people a chance to vote. And I see we have a typo. I just discovered that Facebook has changed the interface, so I'm learning as I go here. Okay. All right, we've got results, so I'm going to show the results here. So 29% of people were diagnosed less than 1 year ago, 33% 1 to 3 years, 27% 3 to 5 years, and 2 of us, well, 3 if you count me, were diagnosed more than 5 years ago. Thanks for sharing that. So today I'm going to start talking about what is ROS1 positive cancer. ROS1 is a gene. We all have it. We don't know for sure what it does. It seems to be most active in embryos and possibly young children, and doesn't seem to do an awful lot for adults, but we still have the gene. This is actually a good thing for cancer treatment, because if we can find ways to block the activity of that gene or the proteins that the fusion creates, then we can turn off what is making the cell behave like cancer without necessarily causing a lot of side effects. However, we don't have a mutation in the ROS1 gene by itself. The ROS1 gene pairs with another gene in the DNA. And what this means is that sections of the genetic code within the gene get swapped between the 2 genes. All genes make proteins in the cell. ROS1 is also the name of the protein it makes. Well, when this gene fusion, or some people call it a gene rearrangement, happens, the protein that gets made is always stuck in the on position. So it's always signaling in the cell, telling it to make infinite copies of itself, go out and invade your neighbors, explore the universe, never die, and the cell behaves like cancer. There are 13 cancers to date that have indicated they have ROS1 positive fusions driving cancer, but it's always a small percentage. In lung cancer, which is the only one that's currently tested for ROS1 as standard of care, it's 1 to 2% of patients have ROS1 positive cancer. But it's also available, and I'm going to have to read this off my other screen, in angiosarcoma, breast cancer, cholangiocarcinoma, colon cancer, gastric cancer, glioblastoma, melanoma, liver cancer, non-small cell lung cancer, ovarian cancer, pancreatic cancer, epithelioid hemangioendothelioma, if I got that right, inflammatory myofibroblastic tumors, and then the additional tumors they found in pediatric brain cancers. So there's actually a clinical trial for our drug being tested in children, and it seems to be working. So when these cancers develop a ROS1 fusion, or when cells develop a ROS1 fusion, they behave like cancer. Enter targeted therapies. A targeted therapy is a pill that we take, in my case twice a day with crizotinib, and there are other drugs that I'll mention later. And those targeted therapies go into every cell in the body, find the ROS1 protein, and there's a pocket on the cell, on the protein. Imagine something about a C shape. And that pocket there is where the protein gets its energy to be able to do its job. So the ATP is an enzyme triphosphate that brings energy into the cell, binds in that pocket, and lets the protein have the energy it needs to work. What our targeted therapies do is go and bind in that pocket and block the pocket so ATP cannot bind. It effectively turns off the energy supply for that protein and turns it off. The protein stops signaling, and therefore the cell stops behaving like cancer. So here's the problem. The protein stops signaling, but the cell is still alive. A lot of these cells are addicted to this ROS1 fusion, meaning without that ROS1 fusion actually making the ROS1 do its thing, the cell will die. So when we take these targeted therapies, in the initial 1 to 2, maybe 3 months, we'll see, hopefully, a lot of tumor shrinkage. But then for pretty much everybody, the shrinkage slows down or even stops. However, the drug is still inhibiting the cancer. So you might show on a PET scan that you have no active cancer, but a CT scan might still show the tumors are there. It doesn't necessarily mean all the cancer's gone away. The cells just aren't behaving like cancer. In some cases, if the tumor was small enough to begin with, or if the crizotinib or the targeted therapy is really good at doing its job, then all of the cancer seems to disappear. As in my case, I started taking that drug in November of 2012, crizotinib, and I have had no evidence of disease ever since. That's 7.5 years. My tumors were really small. We don't know if all of the cancer is gone from my body. There's no way to tell. We can't see it on CT scans. We don't see it on PET scans. But it could still be there microscopically. And since this drug is inhibiting the ROS1, not killing that protein or the cell, if I stop taking crizotinib and there's any microscopic disease in my body, the cancer is going to come back. So I'm not going to stop taking my drug. The very first targeted therapy, Gleevec, was designed and used for, now I'm going to blank, but I know one of them is GIST, which is a GI tumor. And it came out in 2001. There are people who are still taking it and doing very well. But all of them, when they're stopped taking it after 2, maybe 3 years, the disease comes back. Our concern with if we stop the targeted therapy and the disease comes back is that the cells might have had an opportunity to mutate in another way, and then our targeted therapy won't work anymore. So the general consensus among the ROS1 experts is if you're taking a targeted therapy and it's working for you, you don't stop taking it. Now, some people may have trouble with the side effects, and they might be able to reduce the dosage of the drug to deal with the side effects, or they might be able to switch to a different ROS1 drug. So what are our current targeted therapies? The first one, which got approved in 2016 in the US, was crizotinib. That's the one I'm still taking. The next one, which just got approved, I believe, last year, my chemo brain doesn't remember all this stuff, is entrectinib. Entrectinib has the advantage over crizotinib in that it does treat the brain effectively. Maybe 30 to 40% of ROS1 patients tend to develop brain mets. Crizotinib does not treat the brain effectively. So the advantage of entrectinib is that it does get into the brain. However, studies have shown that if you take crizotinib and your cancer progresses, and your cancer progresses in the body, entrectinib will not effectively treat that cancer in the body. However, if you took crizotinib and it was working in the body, but you happened to develop brain mets, some patients have done well switching from crizotinib to entrectinib to be able to treat the brain mets, and it still seems to keep the body under control. Entrectinib and crizotinib are very similar chemically. So entrectinib got approved in the US without saying whether it was a first or second line drug. But it's really a first line drug. You only take it after crizotinib if you've progressed in the brain and you're stable in the body. There's another drug that is available because it was approved for ALK-positive cancer called Serotonin. And it can work first line for some patients, and it does treat the brain, but it is not approved for ROS1, so sometimes we have trouble getting it paid for by insurance in the US. It has been used effectively as a first-line drug in other countries. Hi, Catherine. Yeah, hooray for the doctor who worked on entrectinib. Yep, it's a great drug. Entrectinib is also being used as treating pediatric brain cancer patients. And it'll be interesting to see how that develops. So hopefully they will find our group eventually. Another drug that's available is lorlatinib. And that is available because it was approved for ALK-positive cancers in the US. It is not approved for ROS1 cancers. However, many doctors have been successful if they're willing to write a letter and show the evidence from the lorlatinib trial for ROS1 patients. They've been able to get ROS1 approved by insurance for their patients. Lorlatinib does treat the brain and the body. It's considered a second-line drug to take after crizotinib. It does appear to treat some of the resistance mutations that develop on crizotinib. I haven't seen it analyzed for the resistance mutations on entrectinib because entrectinib is relatively new. But that doesn't mean it won't work. However, it doesn't work as well as we'd like it to. We had hoped it would be effective against some of our more stubborn resistance mutations, but it doesn't seem to work as long as we would like. People who have brain mets find it treats the brain mets fairly well, but it doesn't seem to keep the body under control once resistance mutations have developed. So what is a resistance mutation? Remember that little pocket I talked about on the ROS1 protein? The molecule, crizotinib, entrectinib, lorlatinib, are all designed to go and bind in that pocket. But that pocket has a particular shape, and the molecule has a particular shape. once the protein has been exposed to this drug for a while, it picks up some mutations, and some of those actually block the pocket. So imagine that another little bit of atoms gets added on to the molecule like this, and now the targeted therapy can't get into the pocket. One reason that lorlatinib was developed is that it was a smaller molecule than crizotinib, so it can still get past that block in some mutations and get in there. Another drug that's in clinical trials called repotrectinib is even smaller, and it can get in there. So how do we know whether these drugs will work? In the lab, researchers use cell lines to study how these drugs work. There weren't any ROS1 cell lines when they first started, so they took a standard cancer research cell line and modified it to force it to have a ROS1 rearrangement. And then they test these drugs against it. And they test them to see how much of the drug binds, and then they also test it against known resistance mutations to see how well it works. The most effective one is crizotinib, and I'm going to block a little bit. There are different levels. They call it, the technical term is IC50, and that tells you how much of the drug you need in order to be able to inhibit the ROS1 fusion. And I'm not remembering which one has the highest IC50 at the moment. But crizotinib, being a first-line drug, is the one that generates a resistance mutation. So then they took those resistance mutations they discovered with crizotinib and tested these other drugs against it. And I think it's like 1/3 to a little under half of ROS1 patients, if they develop resistance to crizotinib, develop a mutation that blocks that pocket on the ROS1, and it's called G2032R. Isn't that a great name? Well, they name it based on where it is on the DNA, so I'll let them have that name. But it's very stubborn. Crizotinib doesn't work on it. Entrectinib doesn't work on it. Lorlatinib, we hoped would work, but it's not very effective. Repotrectinib seems to work for some people in the current clinical trial against that resistance mutation. There are a couple of other known resistance mutations where there are actual atoms added to the ROS1 protein. Unfortunately, at least half of the resistance mutations they've found so far in testing at University of Colorado and at Massachusetts General Hospital are not mutations in the ROS1 protein. So when we get a mutation in that pocket, like that blocks the pocket, or somewhere else on the protein that gets in the way, they're called on-target mutations or resistance, because the target is the protein. But if some other part of the cell changes, and for whatever reason the drug doesn't work anymore, or the cell can still behave like cancer even though the ROS1 fusion is getting inhibited, then it's called off-target. And at least half of the ROS1 patients who progress have an off-target mechanism. That's something that I'll ask Dr. Kamish to talk about. We're just starting to research it and find out what our options are for that kind of treatment. There are other drugs that are a little more harsh that might be used, and all of these are listed on our ROS1 website, ros1cancer.com, on a page that talks about the drugs available. We list all of the known drugs, targeted therapies that work for ROS1 in one way or another, and what evidence there is for them. So there's another one called cabozantinib. It's developed for another cancer, and it's been approved for a long time. It's very effective against ROS1, but it's really hard to take. Pretty much every patient who takes it for the other cancers and for ROS1 cancer finds after two months, maybe 3, they have to reduce the dose because the side effects are so severe. So it has not been a first-line treatment, and it's usually held until other things don't work. So right now, the typical patient might start on crizotinib or entrectinib. And if that doesn't work, I mean, ideally, we'd like them to get a biopsy and find out what resistance mutation they've developed. But that's just not standard of care yet. So most patients might go on to either the repotrectinib trial or lorlatinib, or possibly cabozantinib, but hopefully they tried the others first. And if that doesn't work, chemo tends to be effective for a lot of patients. For some reason, ROS1 responds really well to pemetrexed, also known as Alimta. And some patients do well for a long time on a combination of a platin drug like carboplatin along with Alimta. So I hear everybody asking, what about immunotherapy? Well, unfortunately, immunotherapy doesn't seem to work for most patients who have targeted oncogenes like EGFR, ALK, ROS1, RET, a lot of others. In fact, there hasn't been any that's worked in a trial for ROS1, at least as a single agent. Now, the downside of trying an immunotherapy is that they do have side effects, and one of them is pneumonitis and inflammation of the lungs. And there are also some other issues that might arise. And for some patients who take an immunotherapy and have those side effects, they no longer can take a TKI because of the problems with pneumonitis or other side effects, or they might get too sick. So immunotherapy is considered a last resort for patients who have ROS1 positive cancer. Now, there are lots of clinical trials looking at combinations of drugs, and I'll let Dr. Kamich talk about that. So essentially we have crizotinib. Some people start serotonin because it gets into the brain. A lot more people are starting entrectinib because it gets into the brain as our first line targeted therapy drugs for ROS1. After that, you might try lorlatinib, the clinical trial for repotrectinib, which is open worldwide, or possibly cabozantinib, because a lot of countries have more options for that. Or if you can't get a targeted therapy where you are, chemo might be an option, although we don't know how well it gets into the brain. Some patients who are on a TKI and find it keeps their body well under control might try having radiation to the brain, not whole brain radiation, but stereotactic radiation, very focused on just where the mets are. Or if they even develop a met in the body somewhere, sometimes they can have that treated with radiation and stay on their targeted therapy for a long time. And there are actually clinical trials now that are trying to prove that out. That approach called weeding the garden has been around for years, and it works well for people. In University of Colorado, they did a study looking at all their patients with ROS1 who had been on crizotinib. And by using radiation therapy for recurrences, they've been able to have patients with an average overall survival of 48 months. In fact, I take it back, 51 months. So over 4 years on this drug. So that's hopeful compared to our previous, but we'd sure like to see more. So let's see. If you want to look at some of the side effects you might expect with crizotinib, there is a page on our website that compiles the ROS1ders experience with dealing with crizotinib. And we're working on documents for entrectinib and for lorlatinib. But we would like, oh, I see Marlene. Hello, Marlene. I would like to be able to say we have lots of research going on in ROS1, but there's not as much as we would like. And part of the reason is there's not a lot of tissue and not too many hospitals see ROS1 patients. In fact, most lung cancer doctors will never see a ROS1 patient. There's not that many of us. In the hospitals where they tend to see more ROS1 patients, they're doing more research on it. University of Colorado, Massachusetts General Hospital, Memorial Sloan Kettering is seeing some. University of California, Irvine is having some. There's a few other locations. So if you have ROS1 cancer and you want a second opinion, or you want to find out what your next treatment step might be, we have a list on our ROS1cancer.com website of ROS1 experts. These are the doctors that have seen a lot of cases of ROS1. And they're more likely to be able to give you an idea of what your next treatment option would be given your particular case. I see Carol posted she was on immunotherapy last year and it was effective because you had high PD-L1. I'm glad it worked for you, Carol. The current National Comprehensive Cancer Network guidelines actually say don't use PD-L1 for assessing whether or not a patient is a good risk for immunotherapy if they have an oncogenic driver like ROS1, EGFR, or ALK. Because for most patients it doesn't work. I'm glad it worked in your case. But for most patients, having high PD-L1 when you have an oncogenic driver is not a good indicator of whether or not immunotherapy will work. The best researchers have figured out so far there's something causing PD-L1 to be expressed on the cells that isn't the same as indicating whether or not it would work well. So we tend to try and hold that until after we've tried the TKIs. I hope that wasn't discouraging. I'm glad it worked, and hope that your treatment continues to work well. So we don't have a lot of good research going on yet, and that's something the ROS1ders wants to change. We created our ROS1 cancer model project to try and address this. The researchers told us that one of the things they didn't have were a lot of cell lines to study how the drugs work on patients who develop resistance to the drugs and how well it worked for them. So we started having patients who needed to have a biopsy for their own healthcare to ask for extra tissue to donate to try and make cell lines and to try and make mouse models that researchers could use to study our cancer. So what's a cell line? They take fresh tissue from a cancer tumor and they call it passaging, and they expose it to a certain group of chemicals in a certain order, and what they do is create a group of cells that will live forever outside the body. They are in a little frozen tube, and then they can send them to other researchers to look at. They bring them back up, unfreeze them, and put them in a slurry, and then they can test different drugs against these cell lines. And that's the way a lot of drug research is done nowadays. So we're working with the University of Colorado, Dr. Bob Doble, to try and generate a good set of cell lines. He has several that he's developed now from ROS1 patients, and they're in the process of validating them to make sure that they do have ROS1 and that they behave in a way that is useful to researchers. We also have donated tissue to try and make mouse models. And in mouse models, they take the fresh tissue and they inject it under the skin in a mouse, and they then grow that tissue out, and then the mouse is sacrificed, and the tumor is taken out, divided out into smaller pieces, and put in more mice until they can build an entire set of mice that have that particular ROS1 tissue. And then the researchers can use those mice for doing research. We also contributed data to an epidemiological study where they were trying to look at what are some of the common treatment experiences and environments that ROS1 patients lived in, but we weren't able to get much out of that study yet, aside from the fact that a lot of people don't get initially diagnosed with ROS1. Carol says maybe it was the Olympia that was working well. That could be. Olympia by itself works well for a lot of patients. We're also looking at other options and talking with researchers. We're planning to have a roundtable with researchers later this year to talk about what our next steps for research might be. We might end up doing a study where we gather information about ROS1 patients and what it was like on our various drugs to be able to share with the researchers. It would be great to be able to gather data to look at what best drug sequence should be used to help patients have the best results. So there are a lot of different options we're looking at. Yep, hi Lillian, replying to Carol. Yep, it could be Carol, and people who respond to immunotherapy could be an exceptional case. We don't know everything about ROS1 by a long shot. And there's been more than one patient in the ROS1 group who said that they did well on immunotherapy. It usually seems to be a year or two, and then they progress again. And if somebody remembers something different, let me know. I see we have more people in the group now. I'm going to take a quick minute to reopen the poll. If you've already voted, please don't vote again, but I just want to see how many more people we've got here in the group. So the poll is up now, asking how long ago you or the person you care for was diagnosed with ROS1 positive cancer. And I will show the results as they come up here. Let's see if I can do that. People, I think, can still vote while the results are open. Is anybody not able to vote? I can see in the comments if you tell me that. So, all right, well, it doesn't seem to be changing much, so I'm going to reopen the poll. If you have any questions of things that I haven't covered about the basics of ROS1, let me know. While this poll is open, I'll talk a little bit about the ROS1ders. We have been fundraising. Oh, you can't see the poll? The poll should be right on your screen in Facebook, Catherine. Oh, I see somebody voted, so at least someone else can see the poll. All right. All right, I'm going to go ahead and close it. Here's the results, so you can see what they are. So it seems the majority of people are diagnosed 1 to 3 years ago, or at the largest number of people. All right, I'm going to close that for now. So we will be having, excuse me, a video later with, later this month, hopefully, with Dr. Ross Camage at the University of Colorado, and have him talk about the research that's been done on ROS1 and what we know about our different drugs and sequencing, and also what options do we have once we've tried the TKIs and tried chemo and we're still progressing, which is the case for some people. Catherine, I'm glad you found the poll. Hi, Ellen. Okay, your husband was diagnosed 4 weeks ago. I only left the poll up for a little while there. And if there are other questions that you would like Dr. Camage to answer, please type them in the comments here on this Facebook Live, or share them later in our private Facebook group. Now, this video is going to be posted on our website and in our public Facebook group, the ROS1 Cancer Research Forum, and on Twitter. So don't share information that you don't want made public. And Catherine's coming up on her 1-year anniversary of her diagnosis. Congratulations. Cancerversaries are complicated days, but I like to at least acknowledge mine because I'm still here. And I hope that a lot of us are going to be able to be here even longer with ROS1. So if you have any comments, kudos, complaints regarding this video, please add them in the comments there or post it later in the group. And thank you very much for listening. I'm going to end it now.